Standardized intrapartum interpretation and management. In healthcare, and even more so in labor and delivery, a standardized, evidence-based approach to intrapartum FHR interpretation and management necessitates a shared mental model. Shared mental models imply team performance improves if members share an understanding of the task to be performed. For example, if a clinician interprets a FHR tracing as sinusoidal, he or she understands that this pattern is abnormal. The clinician conveys the findings to colleagues, such as a physician who reviews the tracing. After a systemic review of the tracing and clinical situation, a cesarean delivery is called. Because team members used a shared mental model, urgent tasks were performed together with a common goal of optimizing perinatal outcome. In other words, standardized interpretation and management is critical to maternal fetal well-being as long as effective teamwork and meaningful communication occur. Intrapartum Efm is meant to assess adequacy of oxygen transfer during labor. The following two evidence-based principles in intrapartum FHR interpretation can be inferred when clinicians review a FHR tracing. Principle 1. Variable, late, and/or prolonged decelerations indicate interruption of oxygen transfer from the environment to the fetus at one or more points. Principle 2. Moderate variability and/or accelerations reliably exclude ongoing hypoxic injury at the time they are observed. These evidence-based principles create the groundwork for a standardized approach to FHR management, referred to as the ABCD approach, as follows. A. Assess oxygen pathway and identify the cause of FHR changes, both maternal or fetal. B. Begin corrective measures. C. Clear obstacles to delivery. D. Determine a delivery plan. This process incorporates the NICHD definitions and principles of interpretation. The A of ABCD. FHR and UA interpretation requires the ability of reliable and useful data. Clinicians should identify and minimize potential sources of error so data are recorded satisfactorily for interpretation and management. For example, if an external ultrasound transducer is not able to transmit a continuous tracing in a high-risk obese patient, placement of an FSC may be required. Once reliable data are confirmed, a systemic approach to evaluating 5 FHR characteristics is performed. Baseline rate, variability, accelerations, decelerations, and changes or trends over time. Tracing evaluations are completed periodically at reasonable intervals in accordance with institutional policies and procedures. If a Category 1 pattern is identified, the tracing is considered normal because this is reflective of a normally oxygenated fetus. On the other hand, if a Category 2 or 3 pattern is identified, a prompt, methodical approach to assessing the oxygenation pathway should be completed to identify a potential source of interrupted oxygenation. The B in ABCD. The second step in the ABCD approach is to begin corrective measures, or B. Once FHR assessment is complete, the data obtained should guide the interventions that are physiologically appropriate. This requires clinicians to take action to implement procedures that may maximize oxygen delivery to the fetus. This is sometimes referred to as intrauterine resuscitation. Each intervention is centered on the type of FHR characteristic observed, and a systemic approach ensures that FHR characteristics do not go unnoticed, so decisions are made in a timely manner. Sometimes more than one intervention may be implemented to resolve Category 2 or 3 pattern, and not all corrective measures will be used in every clinical scenario. Corrective measures commonly performed include, but are not limited to, the following: maternal repositioning, intravenous fluid boluses, administering oxygen, reducing UA, correcting maternal hypotension, performing amnio infusion, modifying second stage pushing efforts. Maternal repositioning is a corrective measure. Two situations exist in which a maternal position change may improve fetal oxygenation and utero-placental perfusion to return an FHR pattern to one that is considered normal. First, repositioning to lateral or hands and knees will alter the relationship between the uterine wall, amniotic fluid, fetus, and umbilical cord. In this case, variable or prolonged decelerations related to umbilical cord compression may be reduced. Second, lateral positioning may increase uterine blood flow, which may have been decreased by aortocaval compression during supine positioning. The supine position is associated with an undesirable impact on maternal hemodynamics, including decreased venous return and cardiac output. Because the weight of the gravid uterus, amniotic fluid, placenta, and fetus or fetuses compresses the aorta and inferior vena cava. This compression decreases utero-placental perfusion, which inhibits the delivery of oxygenated blood to the fetus. Utero-placental perfusion and fetal oxygenation depend on maternal cardiac output and intravascular volume. An IV fluid bolus of 500 to 1,000 ml of isotonic fluid such as lactated Ringer solution can improve cardiac output by increasing circulating volume, venous return, left ventricular and diastolic pressure, ventricular preload, and stroke volume. Increased volume will affect maternal cardiac output and utero-placental perfusion, resulting in improved fetal oxygenation. IV fluid boluses of fluids containing glucose should be avoided because of potential maternal and fetal complications. Fluid amounts in high-risk women who are at high risk for volume overload and pulmonary edema should be carefully considered. Fetal oxygenation depends on maternal blood oxygenation and flow into the intervillous space. Administering supplemental oxygen to the woman can increase maternal PO2. This increases partial pressure of oxygen that is dissolved in maternal blood and the amount of oxygen bound to hemoglobin. In turn, this can increase the oxygen concentration gradient across the placenta, which eventually leads to increased fetal PO2 and oxygen content. The optimal mode and duration of administration has not been established. This method should be used only if other corrective measures have been implemented. Indicated, oxygen at 10 liters per minute by a non-rebreather face mask for approximately 15 to 30 minutes may be used. Once moderate variability returns to the tracing, fetal hypoxemia is typically ruled out, so oxygen is no longer indicated. The peak of a uterine contraction produces a temporary cessation of uterine blood flow and oxygen delivery to the intervillous space. Uterine hypertonus also may affect oxygen delivery. Typically, residual oxygen in the intervillous space is adequate for the fetus to tolerate these changes. Tachysystole, prolonged contractions, hypertonus, or inadequate relaxation time between contractions may result in FHR changes that are the result of fetal hypoxia. As well as maternal repositioning or an IV bolus, interventions to reduce UA may include the following: removal of prostaglandin cervical ripening agents, decreasing or discontinuing oxytocin, assessment to rule out conditions such as chorioamnionitis or placental abruption, administration of a tocolytic agent such as beta sympathomimetic agent, correcting maternal hypotension, measure to be considered to increase utero-placental perfusion and fetal oxygenation. Hypotension may be caused by supine positioning, inadequate maternal hydration, decreased venous return, and reduced cardiac output, and peripheral vasodilation secondary to sympathetic blockade during neuraxial anesthesia, such as an epidural. Therefore, lateral repositioning and IV hydration are usually sufficient to correct hypotension. If these corrective actions do not increase blood pressure, medications such as ephedrine or phenylephrine may be necessary. Amnioinfusion requires instillation of isotonic fluids such as lactated Ringer solution or normal saline through an IUPC into the uterus to restore amniotic fluid volume to normal or near normal levels. The physiologic principle behind amnioinfusion is that decreased amniotic fluid or oligohydramnios can cause interruptions in the oxygen pathways via umbilical cord compression, which can lead to variable or prolonged decelerations. Replacing fluid, umbilical cord compression may be relieved, resulting in optimal blood flow through the umbilical cord vessels with oxygenated blood. Amnioinfusion rates and amounts are directed by institutional policies. One suggested guideline includes an initial bolus of 250 to 500 ml over a 20 to 30 minute time frame via an infusion pump or gravity flow. A continuous infusion of 120 to 180 ml per hour also may be considered. Uterine overdistension should be avoided. Return may be assessed by weighing the underpads. 1 milliliter of fluid is equivalent to 1 gram of weight. Uterine resting tone may be elevated. If there are concerns related to intrauterine pressure, the amnioinfusion should be temporarily discontinued for a more accurate assessment. In the second stage of labor, maternal pushing efforts can be associated with Fhr decelerations. The consequences of closed glottis pushing or Valsalva-style pushing include maternal hemodynamic changes, increases in intrathoracic pressure, and Fhr decelerations. This causes the following: decrease in venous return to the heart, decrease in cardiac output, reduction in maternal arterial pressure, decline in blood perfusion in the intravillous space, resulting in decreased oxygen supply to the fetus as evidenced by a lower pH and PO2 of the umbilical arterial blood. Modifying second stage pushing efforts may correct this situation. Suggested approaches to pushing include open glottis rather than closed glottis pushing. With closed glottis pushing, the woman is encouraged to take a deep breath, hold for 10 seconds, and repeat 3 or 4 times with each contraction. Instead, open glottis pushing encourages women to push when there is an urge to bear down. Rather than holding her breath for a prolonged time, women are asked to push for approximately 6 to 8 seconds, repeating 3 or 5 times during each contraction. Women also should take several breaths between pushes and be reassured rather than chastised if they grunt or make a deep guttural sound while pushing. Alternative pushing efforts also may include shorter individual pushing efforts, pushing with every other or every third contraction, and pushing only with perceived urge. In fact, passive descent with the woman who does not have the urge to push may be considered when there are no maternal fetal conditions that require an expedited delivery. After performing corrective measures, if the pattern returns to Category 1, continued surveillance is possible as long as surveillance is performed in a reasonable time frame. Category 2 patterns require continued surveillance and further evaluation. In a situation in which moderate variability and/or accelerations without significant decelerations are present, heightened observation is appropriate. In other situations, Category 2 patterns are more challenging, making interpretation difficult. Despite using a shared mental model, the healthcare team may disagree on interpretation or level of risk. In these cases, a standardized approach to management of Category 2 patterns may be implemented. At the other extreme of the fetal monitoring spectrum are abnormal patterns, or Category 3. Expedited delivery whether vaginally or operatively, may be considered for a Category 3 pattern, depending on the entire clinical situation if corrective measures are ineffective. The C in ABCD. Anytime clinicians are uncertain about the clinical situation, the management model guides clinicians to the next step, C, clear obstacles for delivery. When moving to this step, there is no obligation to make critical decisions about time or mode of delivery. This part of the management model encourages the entire healthcare team to focus methodically on potential areas of delay that could prevent a management plan from being performed in a timely manner. Potential obstacles include the hospital, the staff, the woman and her fetus, and the actual labor process. The D in ABCD. The last step in the ABCD approach, D, is to determine the decision to delivery time. Clinicians, regardless of their position on the team, should continue to use a shared mental model to ensure all steps of the management approach have been completed. Decisions to expedite delivery via cesarean section or operative vaginal delivery versus waiting for a spontaneous vaginal delivery is based on the best available information. If a decision is made to expedite delivery, the rationale for delivery is documented and the plan is quickly implemented. In these situations, an umbilical cord blood gas sample may be obtained to assess fetal acid-base status and level of oxygenation at the time of delivery. If the decision is made to wait for vaginal delivery, the justification for waiting and the management plan also should be documented. Ultimately, the person responsible for the delivery will determine the time and mode of delivery. Umbilical cord blood gas sampling is a direct method of assessing the level of oxygenation and fetal acid base after delivery in situations in which a Category 2 or 3 pattern is observed. A double-clamped section of the umbilical cord is obtained at birth. 2 heparinized syringes prevents coagulation, with small gauge needles are used to draw blood gas samples from the umbilical artery, deoxygenated, and umbilical vein, oxygenated. Arterial cord blood best reflects information on blood returning from the fetus to the placenta and best describes fetal status at the time of delivery. A sample from the umbilical vein reflects placental function and the level of oxygenation at the intervillous space going to the fetus. This sample also confirms the accuracy of the umbilical artery sample. Blood samples are stable for up to 60 minutes and do not need to be kept on ice for analysis. Umbilical cord blood gas samples are analyzed for pH, partial pressure of carbon dioxide, PCO2, partial pressure of oxygen, PO2, bicarbonate, HCO3 levels, and base deficit or excess. This information helps identify the presence or absence of fetal acidosis. If acidosis is present, respiratory, short-term acidosis can be distinguished from metabolic, prolonged, or mixed acidosis. Assessment, frequency, and documentation. Documentation of clinical care in a medical record is critically important to communicate information that is complete, factual, and an objective report of relevant information and care provided. Clinical information about the woman and fetus is documented throughout labor. Documentation tools used to chart patient care during the intrapartum period include flow sheets, clinical pathways, checklists, summary notes, or plotted graphs, such as vital signs. These tools may be on paper, in an electronic format, or a combination of both methods. The institution should have a documentation policy that highlights documentation tools to be used, style, format, and frequency interval. The nursing professional organization AHWAN has a position statement that has suggested frequency of assessment and documentation parameters when auscultation, palpation, and EFM are used during the intrapartum period. At a minimum, a systemic approach to assessment and documentation should include the following. 1. An admission evaluation of the woman and fetus at the time of arrival. 2. Ongoing systemic maternal fetal assessment to include FHR and UA data, as well as changes or trends over time, using standardized definitions that at a minimum must include the following: baseline FHR, baseline variability, presence or absence of accelerations, presence or absence of decelerations, type of decelerations, UA to include frequency, duration, intensity, and resting tone with MVUs if directed by institutional policy. 3. Corrective measures used during labor and evaluation of responses. 4. Communication with the woman and support system. 5. Interactions with providers with response and actions taken. Health information technology in obstetrics. Clinicians play an integral role in health information technology, HIT, continuing growth in a journey to further improve obstetric patient-centered care and safety. These fetal monitoring systems are more comprehensive and include point-of-care charting, FHR and UA pattern interpretation, clinical decision support software, and archiving capabilities. At the most basic level, HIT measures FHR and UA, which is then consolidated and analyzed. Once analyzed, data are interpreted in conjunction with a clinician's clinical knowledge that has been accumulated through hands-on experience and education. This type of computer technology allows clinicians to ask the right questions at the appropriate time, complete structured nursing assessments, accurately determine a correct diagnosis from a multidisciplinary approach, and execute interventions along the decision-making process. Fetal monitoring, education, and competency. Fetal assessment during the intrapartum period requires skilled clinicians to be able to interpret FHR and UA patterns, as well as make clinical decisions based on these findings. Professional organizations have developed guidelines to promote education and standardization in fetal monitoring. Comprehensive fetal monitoring education should include didactic information, such as FHR physiology, and psychomotor skills, such as FSE placement. Ongoing fetal monitoring education and clinical competency are also important to achieve and maintain sound clinical judgment and thorough decision-making proficiency. Role of intrapartum fetal surveillance. Obstetric nurses are typically the primary clinicians who provide patient care in labor and delivery and who are responsible for fetal surveillance. In nursing and in obstetric medicine, standardized definitions, interpretation, and management approaches are continuing to evolve. Both professions, nurses and physicians, agree that monitoring is intended to assess the adequacy of fetal oxygenation during labor. There is also very little argument regarding the difference between normal and abnormal FHR tracings. When there is evidence of an interruption in oxygenation along the oxygenation pathway, fetal surveillance often can alert clinicians to conduct further evaluation and possibly implement corrective measures to improve oxygen delivery. Fetal surveillance also has demonstrated that a tracing often can assist clinicians in determining frequency and severity of interrupted oxygenation so that a management plan can be implemented regarding optimal timing and mode of delivery. Clear documentation regarding maternal fetal clinical concerns should be written and shared with the entire healthcare obstetric and neonatal team. In this era of family-centered care and elevating the standards associated with patient safety and healthcare quality, clinicians at the bedside and in leadership positions should continue to promote the use of evidence-based guidelines and research in fetal surveillance to ensure quality obstetric care in the intrapartum setting. Application of the nursing process. Patient teaching with lack of knowledge. Clinicians may identify any number of patient care challenges when fetal surveillance is used during the intrapartum period. A woman may become anxious if EFM is initiated for oxytocin induction when her birth plan stated she preferred IA and palpation for FHR and UA assessment. Pain that was once relieved with ambulation and hydrotherapy may become intolerable if continuous fetal monitoring is necessary. FHR interpretation may be challenging if narcotics are given in the latent phase of labor. Therefore, true nursing care responsibilities related to fetal assessment should be considered. Assessing the woman's and support person's learning needs and expanding nursing care related to fetal oxygenation and potential interruptions along the oxygen pathway. Assessment. Identify what the woman and her support person already know about EFM, IA, and palpation. Women who have attended prepared childbirth classes or have given birth before may have a basic understanding of the purpose, benefits, and limitation of fetal surveillance. Identifying what patients already know allows clinicians to build on pre-existing knowledge and correct any inaccurate information. If a patient is not familiar with either technique of intrapartum fetal assessment, assess her perception and understanding of each method. For example, does the woman believe an EFM will signal the development of a complication? Does the woman expect that she will be able to use a telemetry system during the first stage of labor? Is the woman comfortable with IA for fetal assessment, or does she worry that something important will be missed? Lack of knowledge contributes to anxiety. Note the anxiety level of the woman when the monitor is used. For example, is the woman afraid to change positions because the FHR becomes intermittent? Does she frequently question why the monitor is not showing how strong her contractions are? Should be answered to the best of the clinician's ability, and then knowledge reassessment will identify information that is still unclear. Identification of patient problems. Because of the prevalence of EFM for labor, one common patient problem is the need for patient education regarding EFM. If IA and palpation are being used, there may also be a need for patient education regarding fetal surveillance. Planning, expected outcomes. An expected outcome criteria for a patient with a need for education is for the woman and support person to express an understanding about equipment, procedures, benefits, limitations, and expected data after receiving education about fetal surveillance. Interventions. Based on the woman's knowledge level, education is provided at the bedside, but is not limited to the purpose and equipment chosen for monitoring, frequency of assessment, and a brief explanation about what is shown on the tracing. Sometimes clarification about how the equipment functions is necessary. For example, women may not understand that there is no safety risk for being attached to an electrical device, especially when transducers are exposed to amniotic fluid. Women can be reassured that the connections to the device and those to the wall current are isolated from each other. When EFM is used during the intrapartum period, women may have questions that should be answered. The following are frequently asked questions and suggested answers. Can I move around with all these straps on? Of course, you can move or reposition yourself in bed because I want you to be comfortable. In fact, I want you to reposition yourself frequently as long as the baby is not having FHR changes that are concerning. Staying in the same position is not only uncomfortable, but doesn't promote normal labor. Sometimes the monitor will be unable to record the FHR continuously or record contractions very well. If you notice this, don't panic. Most of the time it's because the transducer on your belly has shifted out of place and lost contact with the heartbeat. Use your call bell to reach me, and I'll come in and readjust the monitor. If we continue to have difficulties recording the FHR or contractions, we may discuss other alternatives. What if I need to go to the bathroom? If you need to go to the bathroom, we'll unplug the cords from the monitor. We may also be able to roll the monitor to the door of the bathroom. Why is the baby's heart beating so fast? It sounds like a galloping horse. Heartbeat is faster than an adult's heartbeat. The normal heart rate for these little ones is about 110 to 160 BPM. If the rate is lower or higher than normal, we'll review the tracing to see what the potential cause is and then make decisions about interventions that may need to be performed. Why do those numbers for the baby's heart rate keep changing so much? The heart rate of your baby changes because, just like at home, your baby takes naps for short periods and then wakes up. When the baby moves, the heart speeds up, just as yours does when you are exercising. When the baby sleeps, the rate becomes slow and steady. What do those numbers for contractions mean? They change all the time. The IUPC we placed earlier is recording the pressure inside your uterus. The numbers change when you are contracting. The numbers will also fluctuate when you are breathing heavily, coughing, laughing, or readjusting your position. My contractions don't look very strong, but they sure feel strong to me. I know you're discouraged because the contractions on the tracing are not recording as strong as you feel them. Sometimes contractions appear stronger or weaker than they really are because the position you're in, how big or small your baby may be, the position of the baby, and how much tissue is between the uterus and the transducer. Remember, you have an external monitor that has a pressure sensor button. Because it is external and not internal, the monitor will accurately record only your contraction frequency and duration, but not the actual strength, rotating your uterus to determine how strong your contractions are. If we need to record the actual uterine pressure, we'll talk to you about placing an IUPC. Will the FSE hurt my baby? The electrode attaches to the first couple of layers of the baby's skin, similar to the thickness of a dime, which is about 1 millimeter. We already know your baby is head down, so we're very careful to avoid sensitive areas on the head, such as the fontanelles, soft spots, or the face. The alarms on the monitor are really annoying. Can you turn down the volume? Thanks for letting me know this information. I know alarms can be distracting to you because I know you want to have a quiet, calming environment for labor. Alarms beep for a variety of reasons. They let me know things like a transducer has slipped out of place and is unable to record the FHR. Your blood pressure is too high, or if the FHR becomes too low. Let me lower the volume for you. If it's still too loud, let me know and I can mute the sound in the room. I'll still be able to monitor for problems by visually reviewing the tracing. Evaluation. Evaluation of knowledge is ongoing because women may think of questions after initial explanations and as clinical conditions change. Achievement of the goal or expected outcome is evident if a woman and her support person indicate an understanding after each explanation. It may be accompanied by a decrease in signs of anxiety. Application of the nursing process, oxygenation. Assessment. Assessment of the FHR and UA using standardized definitions and a consistent management approach is critical to intrapartum fetal surveillance. Standardized definitions allow clinicians to answer 3 questions. What do we call it? What does it mean? What do we do about it? If answering the first question, clinicians are able to interpret FHR and UA data to determine whether a tracing is normal, indeterminate, or abnormal. The second question can be answered by simply applying 2 principles. Is there presence or absence of interrupted oxygenation? And can hypoxic injury be ruled out based on the existence of moderate variability or acceleration? Assessment of mother and fetus is continuous during the dynamic process of labor. Comparing baseline data with ongoing assessments of FHR patterns and UA will provide an opportunity to observe subtle trends in the data and distinguish between patterns that have similar appearances, for example, early and late decelerations. Once these questions are answered, a standardized management approach using corrective measures to improve oxygenation can be applied to the clinical situation. Identification of patient problems. Interruption of oxygen transfer can occur at any or all of the points along this pathway. This interruption can interfere with fetal homeostasis, leading to a deterioration in oxygenation. Eventually, if left uncorrected, fetal oxygenation progresses from hypoxia to metabolic acidemia. Multiple organs and systems, such as the brain, can experience hypoperfusion, reduced oxygenation, lowered pH, and reduced delivery of fuel for metabolism. These changes cause the fetal system to cascade through multiple cellular events that lead to cellular and tissue dysfunction, neurologic injury, and potentially death. Therefore, an appropriate patient problem is possible fetal injury because of an interrupted fetal oxygenation pathway. Planning, expected outcome. Clinicians have a responsibility to have a plan if an indeterminate or abnormal FHR pattern is assessed. Based on the pattern observed, clinicians need to articulate a clear and understandable plan. Simply stated, if a pattern is assessed as Category 1, the plan would include reevaluating the tracing at specific intervals. If a Category 2 or 3 pattern is observed, the clinician will plan to provide corrective measures that promote adequate fetal oxygenation, report the tracing and outcomes of interventions to the delivering provider, support the woman and support person, and document assessments and care. The expected outcome is that the FHR pattern will maintain evidence of adequate fetal oxygenation, such as a normal baseline rate and variability. Interventions. Once a thorough assessment of baseline FHR, variability, accelerations, decelerations, UA, and changes or trends over time has been completed, the Standardized Management Model, ABCD, is implemented. Using this method will provide a safeguard to ensure important steps in the intervention phase are not overlooked and are accomplished in a timely manner. If the FHR pattern is related to an interruption in the oxygenation pathway and requires corrective measures, the clinician's priority is to identify the cause and take steps to improve fetal oxygenation. Implementing corrective measures in response to FHR and UA data is within the scope of practice of nurses. Most facilities have protocols to give clinicians a framework for these steps. Corrective measures may include both independent nursing actions and delegated medical actions. Regardless of the situation, the delivering provider should be notified. Women may understandably become anxious when the ABCD approach is implemented. Clinicians should always remain calm at the bedside to avoid increasing a woman's fear and anxiety, which can reduce a woman's ability to grasp what is occurring. Another way to decrease fear and anxiety is to explain the clinical situation and reason for corrective measures in succinct, simple language that the woman will understand. Evaluation. Ongoing evaluation of the clinical situation is necessary to evaluate the effects of interventions on the maternal fetal condition. This allows clinicians to determine whether corrective measures were successful. Evaluation will also determine whether the plan was effective and whether an alternative plan should be in place. The outcome is met if the FHR pattern demonstrates adequate fetal oxygenation with a Category 1 pattern.